You feel a sudden, restrictive tightness in your chest. The isolation of that moment sets in quickly as you realize something is violently wrong, but you lack the internal data to know exactly what. You are forced into an immediate dilemma. You must decide if this is harmless discomfort from last night's dinner or a lethal cardiac event unfolding in real time. Guessing incorrectly carries a fatal penalty. Misinterpreting a failing heart as simple indigestion leads directly to delayed medical intervention, and every wasted minute allows more heart tissue to die. A heart in danger does not fail silently. It broadcasts a definitive, undeniable data footprint of physiological signals across the rest of the body. Surviving a heart attack requires treating your own body like an instrument panel. You have to read its telemetry accurately and react before the internal damage becomes permanent. Cardiac pain is rarely a sharp, localized sensation. It manifests as a crushing, heavy, systemic pressure. It feels as if a massive, heavy physical weight has been placed directly over the center of your sternum. The pressure does not stay localized. It radiates outward, drawing a clear path down the left arm and deep between the shoulder blades. There are also critical secondary pathways. A creeping tension often moves upward, locking into the throat and lower jawline. To filter out the noise of a simple muscle strain or gas, doctors rely on the exertion test. True cardiac pain directly scales up with physical effort, intensifying when you walk up a flight of stairs. The inverse rule also applies. If you sit down to rest and that severe pressure almost immediately begins to decrease, the likelihood of a cardiac event increases, compounded by sudden cold sweats, severe shortness of breath, and a heavy sense of doom. When heavy, radiating pressure responds directly to physical effort, the heart is struggling to pump oxygenated blood to meet the body's immediate demands. The behavior of blood pressure during an attack is often counterintuitive, leading to confusion over whether the numbers should surge or drop. In the initial phase, the sudden onset of pain and panic triggers the body to release a massive flood of stress hormones. Looking at this line graph, you can see the effect. These hormones act as a systemic alarm, causing an acute, rapid spike in blood pressure right before the attack hits its peak. But as the heart muscle begins to take physical damage, it loses its ability to function as a mechanical pump. The pressure curve plummets. This catastrophic drop is called cardiogenic shock. It is a life-threatening state where the heart can no longer maintain the pressure required to sustain the body's organs, frequently dropping readings below 90/60. The initial high blood pressure is the body's alarm bell ringing. The sudden crash to low pressure is the proof of internal mechanical failure. In the immediate aftermath of the initial attack, bystanders must determine if the patient is stabilizing or if their condition is actively deteriorating. Critical oxygen starvation manifests visually as cyanosis. Notice the fingertips in this clinical image. A distinct, unnatural bluish tint appears on the fingernails when poorly oxygenated blood fails to reach the extremities. This lack of oxygen triggers a plummeting or highly irregular pulse, which results in sudden mental confusion and fainting. Conversely, a stabilizing patient will experience a slow recession of chest pressure and a return to regular, unlabored breathing. If the blood pressure levels out to a stable, mid-range number, the immediate mechanical crisis of the heart has temporarily paused. Medical professionals follow an absolute rule: time is muscle. Attempting to wait out the symptoms at home ensures that starving heart tissue will suffer permanent, irreversible death. Decoding these physiological signals is only half the battle. The life-saving measure is deploying emergency services the exact second this specific data aligns, rather than waiting for certainty.